Great.
Shall we give 1 to 2 minutes for everyone since I've said that everyone should go and have a cup of tea.
Yeah. Need to let the kettle boil.
So 5 minutes and 9 o'clock we're starting then.
Okay. So they're going to submit their questions by chat, aren't they, Lisa? Are you just then going to collect them and work through them at the end of my slides?
Sorry, can you say it again, Julia?
So that if they have questions, are they going to submit them during the presentation on chat?
Well, that Karina was said, but you should not be worried about that. We'll have that live session. I think it's better to ask questions of face to face, so to say, rather than.
Yeah, that's what I was. So if I just go through all the slides and then
yes.
When I finish, actually my last slide says any questions, so it kind of leads into that anyway.
No.
And then will you just read through the questions and ask me them on their behalf?
Yes.
Okay.
Or we can give the chance to people to actually ask. Why not?
To put their hand up and ask. Yeah.
Yeah, it's easier. Okay. I think it's on YouTube, but there is about 3-5 seconds delay. That's why I thought, well, why did I hear my voice?
Oh, it's weird. I did that last night. All the ICS conference, they've used YouTube to do the live presentations, but there was 2 or 3 sessions happening, and sometimes you'd not quite finish the session and start the next one. If you weren't careful, you could click on the link to the other YouTube and you'd get a live version or a YouTube version or a different session speaking. At one point I had 3 people talking and I thought, what's going on?
Oh no.
Technology, it's great when it works, but we're not quite used to it yet, are we? How many countries do you have people from?
In general, or today? Do you mean today?
Well, today, but I know you cover quite a lot of different countries as a company. I was looking on the website, but today, do you have a mixture?
We have a few, to be honest. Oh, he means it's 19. Like 1, 2. So it's Australia is here.
Wow.
Israel is here. Malaysia is here. Spain is here. I think Ecuador, UK, Serbia, Russia, and I think somebody from Middle East. I don't know personally these people, but I'm sure it's DC's customers.
Okay, excellent.
Yeah, okay. To be honest, Julie, I didn't actually talk much to everyone since I was trying to set up everything on my side. I was actually most of the time muted, so I think it's Portugal is there. So quite a lot of people joined in, and I will keep an eye on those that are joining in as well during the sessions, because I think there might be somebody who was running a little bit late.
Yeah, I mean, obviously we're in so many different time zones with all those different countries, so
good. It's 1 more minute and then I think we can start. So it's whenever you're ready, Julia, I think we can start.
Okay, so we have everybody back. Well, thank you very much to Lisa and to TensCare for inviting me along to give the first of a few presentations that are available from TensCare today. And I'm going to be speaking about the use of electrical stimulation in pelvic health. I will plan to go through the slide set. I understand that Lisa's actually recording this as well, so it will be available afterwards if you want to watch it more slowly or pause it during the presentation. I'm very aware, I was just talking to Lisa about which countries are represented, and we have a range of people from many different countries and we're all in different time zones, I guess. If English isn't your first language, I will try to talk fairly slowly so that you can understand me, but there will be a long question and answer session at the end of the presentation. So if you do miss something or don't understand it, we can go through it more slowly then. So I'm just going to go ahead with the slides and we'll go through the presentation. So this morning I'm planning to go through just a small aspect really of using electrotherapy in pelvic health. I'm going to particularly focus on female pelvic floor muscles, but what I'm going to talk about will apply to male pelvic health. I'm also going to focus on urinary incontinence, but we can also consider some of the other factors that are related to pelvic floor muscle dysfunction. We'll have a look at how common some of the problems are, and then we'll have a look at how electrical stimulation is being used currently today in pelvic health, and then particularly focusing in on the range of products that TensCare have around this area, looking at how e-stim can be used to treat the symptoms of pelvic floor muscle dysfunction. So some of the issues that you may find with pelvic floor muscle dysfunction, and the most common ones that are talked about because they are still taboo, but probably less taboo than some of the other symptoms, and that's bladder symptoms. And that might be having to go to the toilet very often. It might be having to rush to the toilet with urgency. It may be being disturbed at night with nocturia, or actually having leakage, and there are different types of leakage which I'm going to go on to define. More taboo, but actually growing in prevalence and in health professionals actually dealing with it, is the range of problems with bowels, ranging from constipation to fecal urgency and indeed fecal leakage or incontinence. Female patients are also going to perhaps have issues with genitourinary prolapse, and although not all of them are symptomatic, that can affect up to 50% of the female population, particularly more so if they've had pregnancy and particularly if they've had vaginal deliveries with problems, particularly like forceps deliveries or ventouse deliveries. But across the range, it's a very prevalent condition. But as I said, not all of them will be symptomatic. In both males and females, we may find problems of decreased sexual function. And then there are the other associated problems. We do tend to focus in on just the pelvic floor when we specialise in this area, but we mustn't forget that the pelvic floor lives in a person, and that they have hips, they have a pelvic girdle, they have a lumbar spine, and all of those areas can be affected by pelvic floor dysfunction. All those problems in those areas can actually cause pelvic floor muscle dysfunction. And quite often those areas can result in causing pain. So we will be dealing with patients who have pelvic pain, maybe visceral pain of the organs in the pelvis, or maybe joint pain or muscle pain. So if we focus in a little bit more on bladder symptoms, in clinical language, we talk about urinary incontinence, and that would be the complaint of any involuntary leakage of urine. And if you're working in this field and you want to look at these definitions in more detail, I would like to direct you to the reference at the bottom of the page, which is from Halen et al. But there is a whole suite of standardization documents that are available from the ICS, which is the International Continence Society. And the really good thing here is you don't have to be a member of the society to access their standardization documents. They're freely available on the ICS website, so you can actually have a look there and download them. What's interesting when we work with patients or users, I will tend to use the word patient because I'm a clinician, but I know commercially you will talk about users or customers. But the females amongst them, we really don't find them using the language of incontinence. If you talk to the average woman and ask who she thinks of when you talk about somebody who's incontinent, typically they'll think of an older person who's in a residential care home, who's actually having significant leakage, and they don't identify themselves with that incontinent person. So often the better language to use with users is that of bladder leakage. Leakage can be occasional or it can be very frequent. It might be numerous times a day, and it will vary depending on the type of the leakage and the severity of the leakage. But the important thing here as well is that the impact that that leakage has on quality of life is not always directly related to the severity of it. So a woman might be having small amounts of leakage infrequently, but it's having a huge impact on her quality of life. And indeed, with some of the stress type leakages problems, women will actually have a huge amount of avoidance behaviour. So their quality of life is severely impacted because they can't go to the Keep Fit class, they can't go to Zumba, they can't play tennis. They're avoiding all the things that actually make them leak. And so that's what's having the huge impact, although it might not happen very often. For women, the primary cause of urinary incontinence is actually not commonly bladder pathology. It's not that something's gone wrong with the bladder, but the pelvic floor muscles are actually weak and dysfunctional, and they're not actually controlling the bladder properly. If we look at the prevalence of urinary incontinence, and I took this from a presentation by a very eminent urogynecologist from Sweden, Ian Milsom, if you actually look at the population numbers and made urinary incontinence a country, it would actually be the third largest in the world. So this is a huge problem. And I think those stats are actually quite amazing when we look at that. If we turn that into what it means for men and women, we're talking about potentially 303 million women and 121 million men across the world who at any point might have a problem with urinary incontinence. So we're talking huge amounts of people being affected by a condition that in many terms is tried to be normalized. It's actually, it's common, but that doesn't mean that it's normal. So what are the risk factors for urinary incontinence? And down the left-hand side of this slide, you can see there's a huge list of things that you would perhaps expect to see, that it does increase with aging, but it affects people of all ages. Teenagers can have problems with it, but you're more likely to see a higher prevalence in the older population. And obesity, which is a growing phenomenon across the world, is actually a very high impact. And the two pictures on the right hand side of the slide actually show how if you look at obesity and you look at age and you look at BMI, then the older you get and the fatter you get, basically, the more likely you are to have problems with urinary incontinence. Now, we haven't figured out the magic pill to stop us getting older, but there's certainly things that we can do about people getting larger. And tackling obesity is a huge issue. Not surprising, we see pregnancy and number of pregnancies and how we deliver in that list. Hysterectomy for women, different ethnicities have different amounts of problems. White populations tend to be more affected by it. Your mobility may make a difference as to how quickly you can get to the toilet. And other general health problems like diabetes and neurological problems that's not listed here, but that would be in with that issue causing neurological signalling problems to the pelvic floor and the bladder and the bowel can be an impact too. Of course, dementia has an impact. And for women, getting older often means that they find symptoms increasing around the menopause. And so we see a particular peak around the menopause years. Other low urinary tract symptoms and urinary infections can be a trigger to causing urinary incontinence and other comorbidities. If we look at the impact that having urinary incontinence can have on our quality of life, it's really quite surprising that it's up there quite high, actually more of an impact than Alzheimer's and stroke would have, and very close in percentage rates to heart disease, diabetes, arthritis, epilepsy and back problems. So it is having a significant impact, although it's quite silent. And often we'll hear patients saying, oh, I didn't want to go and bother the doctor because they've got more important things to deal with, you know, people with heart issues and people who've had strokes and other problems like that. So people tend to underplay the impact of urinary incontinence. And as a consequence, many people are actually looking for self-help solutions. How does it affect your quality of life? Well, in huge ranges, and for different people it will affect us in different ways. So if we start in the middle at the top, we can see there are physical impacts, and I've already touched on this, where particularly women will avoid behaviours, avoid physical activities, or stop interacting. So it can have a huge impact there. And if we go to the left, another avoidance behaviour is often avoidance of sexual contact and intimacy, so having a huge impact on relationships and our ability to function in that way. Below that, we can think of occupational impacts, not being able to be at work. You can imagine working in a supermarket on the checkout. You can't just dash away from the checkout with a queue of customers just because you've got bladder urgency and you have to rush to use the toilet. So there's lots of absences from work. Patients will talk about having lost employment because of bladder issues. At home, it might mean there's special underwear or special bedding, special precautions with clothing if it's a very severe problem. There's a social impact affecting travel. I mean, COVID has been a nightmare for lots of patients because the safe areas of actually going for an emergency wee, using a coffee shop or using a library or a public building or a coffee shop, of course, they're all closed. At the moment, in the UK, we're in complete lockdown, so there's very limited areas where people can actually access a toilet. So it's a huge impact on deciding when to travel. And even when we're not in COVID, it will have a huge impact. People will think twice about taking a flight or taking a train journey if they're going to need to use the toilet frequently during that journey. And as a result of all these impacts, it has a massive psychological impact. Quite a lot of women have told me over the years that they feel guilty, that it's their fault that they're having this problem. If only I'd done those exercises when I was told to. It's because I didn't do them that I've ended up like this. Sorry, my slides seem to be on some sort of timer, and I hadn't set that up as telling me to shut up and move on, so I keep having to jump back. People will be frightened as well of what the future holds, being a burden, having a lack of bladder control, having odour. That's actually a huge part of the stigma of having urinary leakage, and trying to hide it from people and not tell people and just try and manage it on your own. So if we think of female urinary incontinence, let's look at the definitions of the actual types that we're talking about. And this is going to be important when we're looking at electrical stimulation, because some of the programs that we might need to choose are targeted at the type of incontinence. So across all ages, if we look at prevalence of types of incontinence, stress urinary incontinence is the most prevalent. Although as we go through some of the others, you'll see the last one I'm going to talk about, mixed incontinence, is actually in the majority of people that we'll see as patients, it's the most prevalent, and certainly around the highest numbers presenting in the female population of the middle age, around 40 to 60. That age group tend to have more issues with mixed problems rather than just stress urinary incontinence. But looking at the definition, stress urinary incontinence is the complaint of involuntary leakage on effort or exertion. So if you're coughing, sneezing, running, laughing, that will cause you to leak urine. So it's quite a broad spectrum, and how that will impact on you might be different if it's just a great big sneeze or a cough that makes you leak, or whether it's actually during exercise, so during a class or going for a run. Quite a lot of women will discover that they have incontinence because they decide to do a charity 5k run, for example, and find that they set off running and they're all right, but 5 minutes, 10 minutes into it, they're starting to have a leakage. And that would all be badged under the title stress urinary incontinence. Less common, probably affecting about 11% of women who have urinary incontinence, is urgency urinary incontinence, and that's where you get a loss of urine, but it's preceded by a very strong urge to go to the toilet. And this is usually linked with having to go frequently to the toilet and having nocturia. Women with urge urinary incontinence can often experience something called key in the door syndrome, where they're fine, they're on their way home, they might have been out shopping or been at work, and as soon as they actually get to their front door and they're looking for the keys, they get this overwhelming urge. If their pelvic floor muscles are weak, they won't be able to hold on, and they'll actually leak on the doorstep or as they're entering the house. And that's classified as key in the door syndrome, and that's actually quite common. Clinically, we use a slightly different term to describe urgency urinary incontinence, and we tend to collect the symptoms together and call it overactive bladder syndrome. So you may see people described as having OAB, and that's further subcategorized into OAB dry if you just experience frequency, urgency, and being woken up at night with the nocturia, but you don't actually have urgency incontinence. And OAB wet if you also have urgency incontinence. Now, that's terminology that, interestingly, if you go back in history, was developed by the pharma companies. And if you think about the pharma companies and their commercial marketing, their drugs work on the bladder. They're actually having anticholinergic or alpha beta 3 agonists. And those drugs are actually having a direct effect on the bladder. So it's quite useful that they direct the terminology at overactive bladder syndrome. But not all of that urgency is going to be because of bladder pathology. In fact, in the majority of women, it's nothing to do with their bladder, it's actually their pelvic floor. And their pelvic floor can also inhibit an overactive bladder. So again, the pelvic floor is the key to it for a lot of women with these problems. So the final category that I want to talk about here is mixed urinary incontinence. There are others, and if you look at the standardization document, you'll see it goes into other subtypes of incontinence, but they're far less prevalent. And in the population that are going to be seeking help and dealing with this problem around that menopausal age group, then mixed urinary incontinence is going to be the most prevalent type. And that's just simply that they have times when they have stress incontinence and times when they have urgency leakage. One of those subsymptoms then is nocturia, which is where you're woken from your sleep. And it is important, if we're talking to people with nocturia, that we check that they're not awake because they have a back problem and then they're actually needing to go to the toilet, that it's actually their bladder that's waking them up from their sleep period. Women who have bladder leakage don't usually know any of these definitions. And it's interesting that as healthcare professionals and as companies that develop products for these women, we tend to categorize them into having these types of problems when actually they don't necessarily understand it. So it's important that we have that explanation about how they're leaking and what that means for their muscles and for their bladder function. So as I said, it's a very common problem, and if you have a look at the TV adverts, there are some commercial companies who sell incontinence pads who would have us believe that it's normal and that actually all we need to do is put a pad on it. But as children, we're potty trained and we're taught to be socially continent, and so it's actually against our training, if you like, as adults to then not have control. And putting a pad on still means that the urine is coming out of your body and leaking into a pad, which is the same as a nappy or a diaper. So that's not the situation that our women want to be in, ideally. And if you gave them a choice, they would want to actually solve the leakage and stop it happening and getting out of their body, rather than just mop it up with a pad. So the prevalence figures I've touched on already, but if we look at that in the female population, we're talking about over a lifetime in a woman, it's 1 in 3 women. But actually, if you look further down, it increases with age, and the Hunskar study clearly showed that, a massive study across 4 European countries, that actually it's getting more prevalent as you get older. And in some market research that was done recently in women aged over 40, it was as many as 2 out of 3 women. And I have seen studies that have suggested it's 1 in 2 women over the age of 60, but I actually haven't got the references for that. And it can affect all women of all ages, and not just if they've had children. So we do tend to think of this as an obstetric pregnancy problem, but it's not necessarily so. Women who've never had a baby can have problems with urinary incontinence. But that peak prevalence is going to be around the age of 40 to 60, and particularly around 45 to 55, where the majority of women are going through menopausal changes. So what's the pelvic floor supposed to do then in the control of the bladder? So as the bladder's filling at number 1, the detrusor muscle, which is the smooth muscle of the bladder, is relaxed and it's quite stretchy. It allows the bladder to fill. It should hold over a pint of urine between 400 and 600 mils when it's absolutely at its fullest. And in order to do that, the detrusor is very compliant, so it's very stretchy and it allows it to fill. And during that filling period, the pelvic floor, which is innervated by the same nerves as the sphincter that wraps around the urethra, that is actually has some background tone. It actually has to hold that urine in and maintain that tone. And obviously if we're moving and pressing on the bladder, so if we're jumping, if we're running, if we're coughing, then the pelvic floor has to be able to increase its tone in response to that and then go back to its normal resting tone. Partway through filling at number 2, we'll get the first sensation to go to the loo. So normally if we're busy, so if you get that sensation now while you're listening to me, your brain will probably not bother telling you as long as you've got good control. If it knows you haven't got good control, it's going to start sending the alarm bells at that point, because it's like, you're filling up, you need to go to the loo now, otherwise you might have an accident. But hopefully it's just a subconscious, we're aware that the bladder's filling. And then at number 3, we'll get a normal desire to void. So that shouldn't be urgent. If we overfill the bladder, we might all suffer urgency, but normally we should get a message that we could do with going for a wee and we need to go now. For a lot of us, we'll actually go for a wee socially. So we'll have a coffee break and that's when we'll choose to go, or at a lunch break, we'll choose to go then. So we fit emptying our bladder in around our social activities and our work activities. But actually, physiologically, the bladder should be telling us. So a lot of us are actually losing that actual message of a properly full bladder because we've actually gone before the event. When we actually choose to go to the toilet, it should be a volitional choice. We should have reached a place of safety, whether it's behind a bush. I think the new term for that in COVID is an adventure wee, if you've heard of that. But hopefully it's actually in an appropriate place, hopefully at a toilet. And when we're in a position where we can actually pass urine, and for women, we should be sat down on the toilet seat or in a deep squat if it's a hole in the floor. Now, a lot of women are frightened of sitting on toilet seats. They've had myths passed on by grandparents or aunties or mums and dads that you'll catch something from a toilet seat. So quite a lot of women don't actually sit down to wee properly. And then that makes it difficult for the pelvic floor muscles to relax. If you're hovering above a toilet seat, you can't relax your pelvic floor properly. And then you're allowing your detrusor to contract and let the urine out, but you're actually weeing against a closed opening because the pelvic floor is actually still tight. That can cause problems going forwards. So the pelvic floor should be completely relaxed, and that means we must have a pelvic floor that can contract and can relax. And then when we've completely voided, we go back to number 1 again and it resets itself. So I'm going to move on quite a jump now, having talked about what the pelvic floor is doing, and say there are a number of women who struggle to do pelvic floor exercises. The suggested problem with that is if you teach somebody pelvic floor, about 50% of them, from reading a leaflet or being told how to do it by their GP, are likely to not be able to do it properly. Some of that will be because it's very weak and some because they can't find it. So although pelvic floor muscle training and pelvic floor muscle exercises have a good body of evidence and shows that they work, particularly for female urinary incontinence, there are a number of women who really cannot find their pelvic floor. And as I said earlier, a lot of women are seeking self-help, so they'll be looking for devices to buy for themselves to use, and so they haven't got anybody showing them how to do it. They haven't got a friendly physiotherapist that's actually doing an examination and saying, look, these are where these muscles are, this is how you use them. So stimulation is a way to actually help women to strengthen their pelvic floor. And what I'm going to focus on in the rest of the session is the first bullet, neuromuscular electrical stimulation, where we're actually aiming to activate a muscle contraction. And we can do this vaginally with an anal electrode or with electrodes stuck on the skin around the pelvic floor, so on the perineum. But there are other types of stimulation. I just wanted to include this in this kind of theory session so that it paints the whole picture. So there is a a way of using stimulation to provide neuromodulation. And again, that can be done vaginally or anally or with skin electrodes on the perineum, but it can also be done by electrodes on the tibial nerve in the leg. So PTNS is a form of that, or sacral stimulation. And it can also be done in urology and in coloproctology by implanting a pacer, so an electrical stimulation device is implanted with embedded nerves into the sacral nerves at the base of the spine. So quite an invasive surgical approach. But here the stimulation is trying to modulate the electrical activity to have an inhibitory effect on the detrusor muscle in the case of bladder problems, and to reduce the overactivity of the bladder. Now we can use that, and we do use that, and I'll come on to talk about the frequency settings and the program parameters that we would use to try and have that happen. And then the final type that you will hear around things like the pelvic power chair is actually using electromagnetic stimulation. And that's where there's a chair, the person can sit on it fully dressed, and the electromagnets actually create and induce an electrical current inside the pelvis. There's less evidence to support that in the UK. The NICE guidelines, which produce evidence-based guidance on what we should use, are still not recommending this as a frontline therapy, but there is some evidence, and it is being used mainly in private practices. It's quite expensive to obtain the chair. We're talking about £50,000 or £60,000 to get one, if not more, and the sessions therefore are quite expensive for patients to access it. So we're not going to focus on that. We're going to touch mainly on neuromuscular electrical stimulation, but we'll also be touching slightly on neuromodulation. The other types of stimulation then are the neuromodulation with the SANS, the PTNS. So that's where in the photograph to the top right, you can see there's a little fine needle and an electrode attached to that, and then a reference electrode stuck on the heel. And that's actually putting stimulation in at the tibial nerve, which actually feeds into the sacral nerve roots and has an inhibitory effect that way. And it's used for bladder inhibition and for bowel problems as well. Again, the evidence is not hugely strong for that. Again, NICE are not particularly recommending that as a first-line treatment, but it is used clinically. We can also use a TENS procedure where we can apply skin electrodes over the sacral spine for bladder urgency symptoms, and that is something that we can do with the small electrical stimulation units. But when we're using it in that way, we're not stimulating muscle function, we're actually neuromodulating. And then the other one that I mentioned was the implanted electrodes, the sacral nerve stimulation, where the stimulating leads are actually implanted into the sacral spine, and then a pacemaker box with low frequency stimulation is also implanted into the patient's buttock. Again, that's quite, as I said, quite invasive, quite expensive, but for those patients that who've actually tried other types of therapy and have failed other types of therapy, this can be actually life-changing. They'll have a 2-week test of it before everything is permanently implanted, so you can actually kind of try before you buy and see if it's going to work for you. But I have had patients who've actually progressed to that, and it's been life-changing for them, so I do know it can have a huge effect for some patients. So let's focus on NMES, which is neuromuscular electrical stimulation. And that's where we're actually trying to bathe the muscle that's our target muscle, so in our case, the pelvic floor muscles, at the neuromuscular junction where the nerve meets with the motor unit within the muscle. The number of pulses that are delivered per second, the frequency, is actually going to make the motor unit depolarize. And as that happens, the muscle has a twitch. If a second pulse is received before that motor unit can relax and repolarize, then it stays in a contracted state. So 2 pulses happening in a second will trigger the units in the motor units in that muscle, and then they'll stay contracted if a second pulse comes along. But as soon as no more pulses come, then that motor unit can actually reset itself and it relaxes again. There are different types of motor units in the pelvic floor, which I'll come on to, but for any specific type of motor unit, receiving sufficient pulses per second, it will go into a smoothed contraction, which mimics a voluntary contraction. And that's what we're aiming to get when we're trying to retrain and strengthen pelvic floor muscles. We need to send enough pulses to actually stop the twitch happening and it twitches and stays contracted. So we have to choose our frequencies in order to achieve that, if what we're trying to do is to stimulate the muscle function and strengthen the muscles. When we come to apply vaginal or anal stimulation to the pelvic floor muscles, we need to think about the safety of actually putting that electrical current into that area. So in case of vaginal stimulation, we need to think if there's been any tissue damage, if there's any vaginal infection or any recent hematoma or hemorrhage in that area, that would actually preclude us putting our electrodes into the vagina. It may be that we can still use an external skin electrode or an external stimulation, but we wouldn't want to actually put something against the vaginal mucosa. It may be that the person is pregnant, so we shouldn't use any stimulation in the pelvic area during pregnancy. If we're using TENS for pain relief, that's slightly different. So if we look at some of the obstetric products that can be used at the end of pregnancy for pain relief, for sacral pain, for symphysis pubis pain, and also for pain relief during labour. So that's different. Here we're talking about NMES and stimulating to activate muscles. We just don't do it in pregnancy. And we would be cautious doing it in the 12 weeks post-childbirth because of potential pudendal nerve injury. About 80% of women having their first baby will get some nerve damage, some neuropraxia, and that needs time to heal and recover. And what we shouldn't be doing is diving in and making muscles work beyond their own voluntary function by electrically stimulating them too early. It can actually potentially slow down the reinnervation process. So we should be very cautious in women post-delivery, although that is a prime time that they're going to need to get their pelvic floor muscles strong. We should just hold back a little bit from using stimulation so quickly. Other symptoms there is atrophic vaginitis. If we want to be very up to date, we should call it the genito-urinary symptoms of the menopause. So GSM is the in vogue phrase for that, but we tend to know it as atrophic vaginitis, a very dry vagina because of a lack of estrogen, and stimulation is going to be incredibly uncomfortable if we use it vaginally. But it may be that in some patients who have that, we could actually use an anal electrode and still access the pelvic floor from the posterior compartment of the pelvic floor and activate the pelvic floor that way. If somebody's actually got a urinary tract infection, that's not a good idea. If you've ever had a urinary tract infection, you certainly wouldn't want to imagine having stimulation in that area. And the guidelines around pelvic cancer are a little unclear. In clinical practice, we interpret this as if they've had a pelvic cancer that has been treated and all treatments, including chemotherapy and radiotherapy, are completed, then we should have a conversation with the patient. The risk factors are thought that stimulation could stimulate cancerous cells if they were still present, but the current thinking is that if the surgery or treatment has been completely successful, then that person is no more at risk than another person from having NMES. However, some patients are very risk averse when they've had a pelvic cancer and wouldn't want to take any risk. And some patients are actually so determined to get on with the rest of their life, we shouldn't withhold treatment from them by saying they can't have it. So really we should have an individual conversation with the patient and perhaps their oncologist or their surgeon that's been looking after them and decide whether it's appropriate for them. With abnormal smears at the moment, if you've had an abnormal smear, then we're looking for them to have one normal smear so that we know that the pathology has been removed or it's not a threat, and then it's okay to proceed with having that. On the left-hand side here, we've got implanted cardiac pacemakers. So there are other pacemakers. The sacral nerve stimulator, as I've just mentioned, is a pacemaker device. However, those kind of pacemaker devices can be turned off whereas a cardiac pacemaker cannot be turned off. Now, we know that when you have stimulation in the vagina or the anus, you actually can see changes in brainwave activity. So we know through the neurological system that electrical energy is traveling around the body, and therefore there is considered to be a risk that with any form of neuromuscular electrical stimulation, even if it's inside the vagina or inside the anus, that it is a challenge with an implanted pacemaker, a cardiac pacemaker, so we shouldn't do it. And again, because of the tissue damage situation and the potential neuropathy, then we should actually not do it for up to 12 weeks post pelvic surgery, although that might be on a case-by-case basis, and some clinicians may choose to actually offer stimulation sooner than 12 weeks after a full clinical assessment. When should we be cautious with using stimulation? Well, if there's reduced vaginal sensations, so particularly in neurological patients, MS patients, for example, we need to be careful because they're not going to feel the stimulation in the same way, and they may not know what their thresholds are as to how high to turn the stimulation up. But with support, it can be very useful in that patient population. And certainly one of my colleagues, Doreen McClurg, who's based at Glasgow Caledonian, has done research into that area and shown in an MS population of women that it was really helpful in treating their urinary incontinence. Clearly, if there's a severe vaginal or anal prolapse that's at the vaginal opening or at the anus, then we're not going to be pushing a vaginal or anal probe into there. So that would be a caution, but if it's not so severe, then we can proceed. Looking at the right-hand side, epilepsy is a consideration, again, because we can see changes in brainwave activity when we have vaginal or anal stim. Then we actually need to consider, if this is a stable epileptic, are we putting them at risk of having an epileptic fit by giving them stimulation? And they may choose then not to proceed because it's so important for them to be stable, to be able to drive, to be able to go to work. So that is a consideration that we should have a discussion with them and perhaps with the multidisciplinary team. Any bleeding disorders, so like haemophilia, we need to actually know that they're stable and controlled. Not that the stimulation waves themselves are going to cause a problem, but particularly if you're using a vaginal or anal probe, you're putting it inside and you can't see what's happening, so they could cause an injury with the actual probe. Dermatological skin conditions, they may be so inflamed and irritated that stimulation is not a good idea, but then in other situations it can improve the circulation locally and improve dermatological conditions. And indeed, if it can stop the leakage, then that may well very much help that situation. So that's again a case-by-case situation. In some parts of Europe, it's considered a contraindication if somebody's had sexual abuse that we should not use stimulation, but certainly in the UK and a lot of my colleagues that I do know in other parts of Europe would proceed with caution, obviously, and explaining and consenting carefully with the patient, because it could actually bring flashback memories if you have stimulation in an area where you were abused, but it can be really beneficial for these patients. So again, you don't want to withhold treatment if it might be of benefit to them. Metal in the pelvis shouldn't be a complete contraindication with most forms of neuromuscular electrical stimulation, but there is a particular type out there that is described as a pair of shorts where it's cross-firing 8 channels of stimulation into the pelvis, and metal could actually divert the course of the field of the electrical pathway, and so that would be a contraindication with that product. But with vaginal or anal stimulation, it isn't a problem. So I've just put it there with a question mark just to remind me to mention it. And of course, when we come to look at electrodes, we need to consider whether somebody has a nickel allergy, because a lot of the electrodes out there have a stainless steel electrode plates, and that could cause an irritation to those patients. So we'd need to choose a different type, and I'll mention that as we go on. Just aware of time, so I'll keep going a little bit quicker because time's running away with me a little bit. So what we're doing when we're trying to apply stimulation to the pelvic floor, well, there we are with our vaginal probe. That's the Liberty loop, if you like, and that's, if you look carefully at the image on the slide, I've got a pelvis behind that, so that's actually just positioned over the vaginal orifice, and we're trying to make a circuit with the patient. So we've got a power source in the middle. We're actually sending a circuit of electrical energy out through one of the stainless steel plates, through the muscles, and being collected on the other side and back to the power source. It's a biphasic asymmetrical rectangular wave, if we want to get into the physics of it, and it's a direct current effect because it's going round in the same way. But the energy is depleted because it's asymmetrical and it's biphasic. It's actually building up the energy and then it's dropping the energy down before it resets itself. Because we're not using a normal electrical circuit, if I want to plug my laptop in to charge it up, I have a metal pins on my plug and I connect into the system in the house that has the mains electricity by putting metal against metal, which is a really good conductor. And the challenge that we have with patients is that we get this thing called impedance, and tissue impedance is a particular challenge. If we put a probe in the vagina or in the anus, we're against the mucosal membrane and we haven't got a metal pin plugging them in. So we need quite a lot of moisture there, which anything water-based is a good transmitter of the electrical energy. So tissue impedance, which is measured in ohms based on Ohm's law, can actually affect how much stimulation we can get into those tissues and whether we can get it to a therapeutic level. And so if the muscles are fatigued, they'll contact the electrode differently. Even women at different stages of their menstrual cycle will get different pH values and different secretions in the vagina that can affect the impedance of those tissues. And it's also really important to choose a good fitting electrode so that we have those muscles actually contacting the plates so that we get a good stimulation flow through into the tissues. Using a gel can really help, so any water-based gels such as a KY jelly, and in fact TensCare have their own TensCare Go gel that's a water-based gel that will actually help reduce the impedance and actually make the stimulation more effective. So here we have the range of electrodes. You can see there's ones with electrode plates that run down the electrode and ones that run round in a circle. You're actually just trying to make a positive and a negative contact into those muscles. With the ones that run down the plates, then there is a directional flow, so it will come out of one side and round to the other, depending which way round you've plugged your leads in. With the circular ones, then it will come out of one electrode ring and be collected by the other one, so you're making a circuit in a different way. You'll see the ones on the right hand side of the picture say that they're gold plated. That's not just because we have patients who have expensive tastes and want to have gold in their electrode. That will actually be the ones that you would use if they have a nickel allergy, because gold is a pure metal and they're not likely to react to that, or far less likely to be reacting to that. Certainly a nickel allergy wouldn't react to those. So you would only go to those types of electrodes if you have a problem with a nickel allergy. The other electrodes, you can see I've actually put the size of the diameter of the electrode. So it is important, particularly as clinicians, if we're assessing somebody vaginally or anorectally, but particularly with the vaginal patients, we want to know which is actually going to fit them the best. And the Liberty Loop is the largest one at 34 millimeters, and that actually is the design and size that is the market leader across most of Europe at the moment. And for most patients, that's going to be the best fit, and it's quite lightweight, so it's easier to retain in the vagina if you actually want to be active when you're doing your stimulation. The other probes are slightly narrower, and the Liberty is 28 millimeters, Liberty Plus is 32. So you've got a range of sizes there, but they are slightly heavier, so it might be a little bit more difficult to retain. And if somebody has a very narrow vagina, then you can go down to the Liberty Mini, which is 25 millimeters, which is also used as an anal probe as well as a vaginal probe. And then you have an anal probe with the circular rings as well. That certainly that would not be very easy for a patient to use at home because it's quite a long probe. They'd have to position it, whereas the Liberty Mini actually sits between the buttocks much better, and you can actually be a little bit more mobile with that one. And then we need to choose a program. So what parameters? So those in preset programs, somebody else has decided and put into the machine the frequency, the pulse duration, the duty cycle. I just want to very quickly go through what those different parameters mean and how we might use them with a patient. So frequency is the number of electrical pulses being delivered to the motor units, which is measured in hertz. And the pelvic floor muscles are going to respond to frequencies between approximately 2 hertz to 50 hertz. By 50 hertz, you're getting sufficient pulses per second that all the pelvic floor muscles that are being affected by the stimulation are going to be contracting, and then there's a pulse coming sufficiently soon enough after the first pulse that keeps them contracted. So that's actually going to give you the best overall contraction. If we look at the types of fibre within the pelvic floor, we have slow twitch fibres and fast twitch fibres. Slow twitch will respond between 2 and 10 hertz, and fast twitch are going to respond between 20 and 50 hertz. So at 50 hertz, you're getting all of the pelvic floor working. The downside to that, and why sometimes a slightly lower frequency is chosen if it can be, is that if you're going to do your whole treatment at 50 hertz, you're going to fatigue the fast twitch fibres. They're fast glycolytic, they'll burn their energy off very quickly, and you'll get fatigue much more quickly. So often we choose a slightly lower frequency to hit a re-educational program for the pelvic floor. Pulse duration is actually measured in microseconds, so it's often recalled to pulse width, because when we look at it we see how wide it is, but strictly true if we want to talk about as physiological and physics measurements, it's a duration because it's measured in seconds, so it's not measured in meters, it's measured in seconds. It's the time, and it's the time taken for each individual pulse to start at our zero output, reach its peak, discharge the energy and go back to zero. And the reason that metal in the field, so things like copper coils and marina coils and hip replacements, if you're using anal or vaginal stim, it's not a problem, it won't produce a heating effect, is because of that negative phase. So you've got your energy that makes the muscle twitch, and then you drop the energy out of the circuit with this net zero direct current effect. So its overall effect is zero. It doesn't build up lots of energy in the body and produce heating effect. The longer the pulse, the more impact it may have on the sensory nerves, because we're not just getting the motor nerves that we want, we're going to affect the sensation in that area. So the commonly used pulse duration for muscle rehabilitation is about 250 microseconds, but a lot of the papers that have been done for neuromodulation using vaginal or anal probes actually will use a longer pulse duration to have more stimulus on the sensory feedback mechanism back into that neuromodulation to the bladder. The duty cycle, often talked about as a work-rest ratio, which makes a bit more sense. So it's how long each phase of stimulation is going to be, where we've stitched those pulses together in a frequency, and then how many seconds of that we're actually going to give the muscle. We need to protect against over fatigue by giving a sufficient rest phase. So in clinical practice, it's common, if you've given work, to give an equal rest phase. So 6 seconds of stimulation would be followed by 6 seconds of rest. However, if you think you have very fatigable muscles, it's possible to actually double the rest phase. In fact, I've seen clinical papers where you have a 5 times rest phase to work phase. But the spin-off here is that if you're giving 20 minutes of treatment or 30 minutes of treatment, the longer your rest phase, the less treatment that person's actually getting. So usually we wouldn't go any more than double the rest phase. So that would be something like 3 seconds of stimulation. You perhaps give a 6-second rest phase to allow that patient to recover. But you could also shorten the length of treatment as well. That would help protect again against fatigue. Ramping doesn't have a lot of science behind it. It's basically how many seconds into a work phase it takes to get from the 0 milliamps to the number of milliamps that you've set the machine at. So if you've set it at 20 milliamps, how long is it going to take to get from 0 up to 20? Now, in some devices, that actually takes out of your work phase. So you need to be careful, because if you set a ramp of 2 seconds to get up to your maximum intensity, but your work was only for 3, then actually effectively you're only working at your target intensity for 1 of those work seconds. I think in the TensCare units, when I was looking at the data, it's actually an addition at the beginning, but we can perhaps take that in the question section, and some of your technical guys, if they're around, can explain how it works with your TensCare equipment. You can also do the same at the end of a contraction. So a lot of programs will be set at about round 1 in clinical practice. Myself, I will use half a second, because 1 is quite a long time to get there. So as long as the patient's not very oversensitive to stimulation, I would tend to set that at 0.5 of a second clinically. How long we treat for, It really varies hugely. If you look at the clinical research, there is a huge range, but the average is around 20 to 30 minutes every day. There are some papers that have suggested alternate days is as effective as using every day, but there are some that actually may use it 2 or 3 times a week. And there's one American product certainly that I know of that uses it 5 times out of 7, so 5 days out of 7 in a week. So it's hugely variable. I think it does depend on the individual, on why they need to use stimulation and what the status of their muscles are as to how much they need to use and how long they need to use it for. Intensity is really important. If we're wanting to actually make those motor units contract, to train the muscles to strengthen them, we actually need to get to their motor threshold, how much energy they need to actually make that muscle go into that depolarized state. Now, the problem we have in the vagina and the anus and skin electrodes for that matter is that we have these things called sensory nerves, and they're going to feel the stimulation ahead of the motor nerves. So you'll feel the tingle, you'll feel the buzz, you'll think something's happening way ahead of actually getting a contraction to happen. And I think this is a huge challenge for men and women who are buying devices on the internet to understand that they have to get to that level. So that's something that we really need to think about, how we communicate that to people. Using some of the treatment parameters that I've already talked about, like how long the pulse is and to an extent that what the frequency is, can actually make that easier and more tolerable. So we need to think about that. So we can actually reduce the pulse duration, for example, if somebody really can't get the intensity up. So using a shorter pulse can actually mean that it doesn't have as much impact on the sensory nerves. So, sorry, slightly over time, and once I get talking, I can't stop, but hopefully I can talk a little bit more in a question section. Hopefully we've looked a little bit about what happens when pelvic floor muscles are not working properly. We've looked at the prevalence. We've talked a little bit about the different types of stimulation that can be used in pelvic health. By all means, I've not gone into a great detail in 20 minutes, 30 minutes. It's not possible, but I can take questions. And then we've thought about how eStim can be used to treat the symptoms of pelvic floor muscle dysfunction. So I have been fortunate enough at one of the ICS conferences to go and visit the Great Wall of China, and so I know if you do need the loo when you're up there, you would hope not to have urgency and certainly not have key in the door, and hopefully didn't even have stress incontinence. So never mind, I can hold it, is what we want our patients to be able to say. So at that point, Lisa, I'm going to hand it back to you to chair any questions.
Sure, I'm actually doing now the round of adding everybody else, everyone else to sort of we can see. I know Andrew had a question that I actually also wanted to ask. Andrew, maybe if you just sort of start by asking whilst I'm sort of adding everybody else to the view mode. Andrew, you muted. You need to mute yourself.
Andrew, you're still muted. We can't hear you.
Okay. Yeah, I was just going to typing when you changed to ask if there's any evidence about if there's any subcategories of patients that eStim is most effective on. You know, where's it most useful to use it?
Ooh.
You know, is it women with very poor pelvic floor? You know, Oxford scores of 2, you know.
It's quite interesting. If you look at some of the guidance documents, then that is clinically where people tend to go, and certainly the NICE guidance looking at the evidence when they've done comparison studies between pelvic floor muscle training and pelvic floor muscle training plus stim. What they conclude from that is that it should be used when people struggle to do a pelvic floor contraction. So if they can't do their contraction. Now that gets translated into clinical practice, and I think a little bit wrongly that people will say, oh, you should only use stim if we have a scale of a 0 to 5 Oxford grading scale, where 0 is you can't do a contraction, 5 is a very, very strong contraction, and that you should only think of using stim if they're a grade 0, 1 or 2. Which fits to an extent. So we are saying you would use it with somebody who can't contract or who has a very weak contraction. Now, I think if you take that out into the general population of women and take the bump and the bow work that we know when women are told how to do exercises very often they get it wrong. About 25% of them are going to be pushing, and about 25% of them are actually not going to be contracting their pelvic floor at all. They might be squeezing their glutes or their abdominals, but not their pelvic floor. So without a clinician there, I think then it becomes a lot broader in that, you know, with stimulation, you're going to make those muscles work. With a clinician, we're probably a little bit more circumspect, and then we might choose to use it with somebody who's weak or who can't contract. But then clinically, I also use stimulation to retrain the muscles. So if I have somebody who I need to have a longer contraction in order to inhibit their detrusor when they've got urgency, but they're a grade 4, so they're a really strong contraction, but every time they squeeze it, they just lose it after a second, I'll use stimulation to train them how to hold it for 10 seconds. So I'm actually kind of breaking the rules, if you like, but in my head they're still weak. They've still got a weakness. They've got a power contraction, but they haven't got an endurance contraction.
No, that's what I wanted you to say, so that's great. Yeah.
Oh, good. We hadn't spoken before, and I haven't spoken to you, Andrew, for many years. I dread to think how long ago it was.
Years, yeah.
I think there's another question, Julie, as well, whether there is any explanation as to which electrodes to use, whether the metal parts that go around the probe or the ones that are sort of alongside the probe. Is there any recommendation on that?
There have been a couple of papers that have looked at comparing electrodes. We have to be a bit careful because those electrodes that I put up are often used for EMG, and they're used for stimulation. For stimulation, my favoured is the longitudinal electrodes because of the position of the pelvic floor. It's not that big a structure. So if you're pushing the ones with the rings on into the vagina, there is a risk that one of those rings is actually way above the pelvic floor level and it's in too deep, basically. Now, because we have a mucous membrane, we will still probably get some stimulation effect, but it's not going to be as good as actually having the electrodes right next to the pelvic floor. The interesting thing here is we don't quite yet know where that current goes when we put those, like the Liberty Loop, for example. That would be my favoured electrode. But I was asked the question recently by a professor of engineering who said, well, where does your circuit go when it comes out of that pole and goes into the muscles? Does it go up and around the top? Does it go out? And the answer is we don't know yet. So we know we can produce a contraction. We know it contracts left and right. We can feel it posteriorly. So you can have a vaginal probe and feel something in your anus. You can have an anal probe and feel something near your urethra or your bladder. So we know we're getting into the muscles, but actually exactly where it's going, we don't know yet. But my favoured electrode at the moment, because of the positioning of it, would be the Liberty Loop, because it's quite lightweight, and I tend not to treat my patients lying down flat on their back. Most of us don't have problems with leakage lying down flat on our back. We need to be active, we need to be upright. So I would want something that stays in place and can move around with it.
Good. Thank you for that. And I think Karina also wanted to ask a question on behalf of our distributor from Brazil. So Karina, maybe if you just ask yourself.
Yeah, they have always a question if they can use electrostimulation when they're having the period. And the second one is if they have any contraceptive device, if it's safe to use it.
Okay, so first question first, menstruation. There is no contraindication for that. It wasn't on the list of when not to use it. It's a little bit of patient choice. The only thing I would say is generally I would say not to use it, because a lot of patients will actually get a lot of abdominal pain and discomfort with their period. And we know that one of the effects of stimulating the pelvic floor is to increase blood flow to that area. That there are studies that have shown that you can increase the clitoral blood flow and you can increase the blood flow in the labia. So we know we're actually getting more blood into that area. So some patients actually find that they actually get a lot more abdominal cramping and a heavier period. So it's not that comfortable for them. But if that's not the issue, if they have quite light periods just because they're having their menstruation, then they still can use stimulation if they choose to. So it's a bit of a patient choice, but it might be. So certainly in an instruction leaflet that I'm not going to be able to have a conversation with somebody, I would probably say avoid it during menstruation. But actually with a patient, I'd say, well, it's your choice. If you feel comfortable, you might want to try it, because obviously if they're having a period for 7 days out of every 28, then that's going to really impact their treatment. You know, they're going to be really slow to make progress because they keep missing a week.
Mm-hmm.
And then the second one, I did touch on that, and it's to do with the waveform that we have in these small devices, which is this biphasic effect. It doesn't build up energy. Way back, because I've been around for so long, that when I first started using stimulation, we had something called a faradic battery, which was actually giving a direct current. And if you had little gauze pads, you had 2 gauze pads, and you put them on the muscle you were trying to work, you would get salts and electrodes building up under one of the pads because of the flow of the current constantly going round. Now, that doesn't happen with this type of neuromuscular electrical stimulation. The positive part of the spike makes the muscle contract, and the negative part depletes the energy out of the system, and then it goes back to 0 again. So there is not going to be any heating impact, which is the worry about metal in the field. The only issue would be, and I know we're in TensCare, but I'm going to name the product because otherwise you won't know what I'm talking about. There is a product called Innovatherapy or Vital. It's like a pair of shorts, and it has skin electrodes in the buttock and around the sides. That is different. It's still neuromuscular electrical stimulation. It's still trying to make the pelvic floor contract. That is actually going to be potentially able to affect metal in the field. So the copper coil, hip replacements, vaginals, jazzles, or whatever with body decoration would all be affected by that, but not with our normal sort of neuromuscular electrical stimulation. And then the other product that I had in the slide set was the electromagnetic chair. You've got to be careful with that as well, because you're trying to put the electrical circuit in more generally, so it could actually be attracted to metal, because the electrical current will take the route of least resistance, and metal is a really good conductor.
Thank you.
Thank you very much, Julia. Are there any more questions?
Yeah, I have one question. Can Julia, what your advice for how long you have suggest patients can use units?
I mean, how many weeks to use it for?
Yes, how many weeks, and usually if they don't have result, then can use after. I know that they can see first results after 4-6 weeks, but how if they don't, how long they prolong using stimulation?
Yeah, I think on its own, they probably need to be seeing a specialist as well, so a specialist physiotherapist maybe, if they're not seeing improvement on their own within 6 weeks. I would have expected them to see some changes, some improvement, yes. Maybe not to be treated or cured, if we want to use that word. Most of the clinical studies, and certainly a clinical study that I was involved in on a different kind of medical device called Pelviva, we actually did it for 12 weeks. So the sort of accepted clinical approach is 12 weeks, because that's how long the American College of Physiology said it would take to actually strengthen muscles. So pelvic floor exercise programs tend to be 12 weeks, and a stimulation treatment course would tend to be 12 weeks. The difficulty we have here is patients are going to come to this using stim from completely different start points. Some might be very, very weak, and it will take them longer to get strong. So I've had patients, it's taken them 4 months, 5 months, 6 months. And then we've got a group of patients who either obstetrically or because of a neurological condition like MS or even in fibromyalgia, the nerve conduction to the muscle is just not there. So if you give them stimulation directly into their vagina, it gets to their pelvic floor. The pelvic floor improves because it's being exercised with the stimulation when it's there. But when you stop the stimulation, they're going to go back to where they were because they simply don't have the neural connection to exercise it themselves. So there will be some patients who are what I tend to call stim dependent. So when I assess somebody that's like that and we try stim, I will counsel them that this might be a long-term thing. You might have to keep coming back and using the stim, maybe not every day or every other day or as much as you would in the treatment phase, but you may have to have a maintenance phase that is permanent. If you've got a neurological condition, you know, we can make people who are paraplegics walk with functional electrical stimulation with calipers and electrodes strapped on their legs, but the only reason that their muscles are working is that electrical stimulation is there. They have no electrical connection themselves. So sometimes the pelvic floor is a little bit like that with poor electrical connections, and they may need to use it long term. But typically I would expect 12 weeks as a kind of very broad rule of thumb.
No, I just wanted to hear in special situation, like with the people with really they have a very weak muscles, and in this situation you said for it is accept prolong using units.
Yeah, and
Okay.
maybe long term.
Yeah.
The good thing about stim is that so far, apart from the electrode going in and maybe causing some irritation or infection, there are no side effects that we've seen in any of the studies. So it's not like taking drugs long term. It's not having, you know, harmful long term side effects. So it is something that we can use. It's mimicking the natural action of the body by using an electrical current more directly. So it is relatively, nothing is completely safe in this world, but it's relatively safe to use long term.
Yeah. Thank you. Thank you.
Good. Any more questions? Dorrit, you unmuted yourself, I'm sure, coming up with a question.
You were sideways.
Yes. Since we are selling most of the cells by the phone, I would like to have some questions which the sales lady can ask in order to avoid selling a product to somebody that would be problematic. So which questions you think we need to ask in order to avoid this?
I'd probably go back to that slide around the when not to use it, and have a look at that. Certainly that you can extend that further in, and in most of your product guidebooks, you have a list of contraindications at the back. So if you just get hold of one of those, you could actually do a little chart. When we're teaching our postgrad students stimulation for pelvic health, we will actually give them a checklist to actually just go through, and that's usually in the back of the patient's clinical notes that they just tick off if they have any of those things, and then they wouldn't give them stimulation. So for example, you know, a recent surgery or a pregnancy, or, you know, if a woman's of childbearing age, that if she's planning a baby, then she needs to know that if she thinks she's pregnant, she should stop using stim. So it's those kind of things you want to capture before somebody starts using it.
So you have the checklist already? Can we have it?
We will send. I think we actually have in our manuals as well. I think we just need to make it a bit of like a checklist rather than just like cautions and warnings. And I'm sure Adiz will email it to you as soon as we finish the workshop.
Okay, and we also get the video of this lecture.
Yes.
Okay.
Sure.
Thank you.
I'm really sorry, but I think we're running out of time, and the next session is about to start in 3 minutes. So I just wanted to say thank you again to Julie for obviously preparing and hosting the session tonight. I think I'm talking on my behalf and on behalf of everybody else. I think we did enjoy quite a few things that we also learned. I learned for myself as well. So I hope you did get something for you as well. If you have any questions later on, you'd always welcome to email them to the people you work from TensCare. You know who to email, and we will either pass on to Julia or we'll be able to answer ourselves. We have brains in our business as well, so I'm sure Andrew would be able to come and rescue us if we need anything scientific. Everything else can be answered by our account managers. Thank you very much, Julia, again, and we'll keep in touch, and there will be another session on that on Wednesday. If you wanted to attend again, then obviously you're welcome. Good. Well, we're jumping on another. I know it's a little bit inconvenient, but since I was doing that first time round, I needed to schedule all separately. So I'll see some of the faces on another link in a few minutes. Thank you. And
Thanks,
have a
Lisa.
nice day, Julia.
Thank
Thank
you,
Bye.
Julia. Thank you.
Thank you.
Uh-huh.